Before I go into this, just a show of hands, if either you or someone in your family has atrial fibrillation. Yeah, that's exactly right. So it's the most common arrhythmia in the United States, and if treated appropriately, people can really live a nice normal lifestyle, but unfortunately a lot of folks don't really get treated appropriately. So let's go through this. So first of all, let's talk about the basic way the electrical system in the heart works. You can look at the heart as a 4-room house. There's 2 upstairs rooms and 2 downstairs rooms. And if you were starting to walk upstairs, you'd go down the staircase. You could go to the right side of your house or to the left side. That's what the heart is. The heart has 4 chambers, 2 upper chambers, 2 lower chambers. An impulse starts at the top. It goes through its own staircase, the conducting system, to get to the bottom. And that provides a nice normal rhythm of the heart. Atrial fibrillation is when the top chambers of the heart beat 400 or plus beats a minute. So just imagine that you're downstairs trying to watch a ball game, comfortably sitting there, and 400 kids are upstairs, all trying to get down at the same time. Now that would wreak havoc on everybody, right? So just like in the heart, you can't, if you go 400 beats a minute, you wouldn't be here at today's symposium, I'm sorry, you would be somewhere not good. So the heart protects you. The heart has its own staircase to protect you. So you have all these beats on the top chamber, but only so many get through. But some people have a really good staircase, so many beats get through. Their hearts may go 130, 40, 50 beats a minute. Others not so good, but the cardinal feature of atrial fib is an irregular rhythm. So you can go really slow in atrial fib, but you'll see your pulse is never normal, or you can go fast, and they'll provide different symptoms for you. And we're going to talk about how to figure out this in a second. So what are the causes of atrial fibrillation? Well, the 2 most important causes are high blood pressure. Over 50% of people with atrial fibrillation have high blood pressure, and older age. As one gets older, there are changes that take place, anatomic changes in the top chambers of the heart, to cause a milieu, to cause a situation where atrial fib can come out. And it's estimated that about 10% of people 80 or older have atrial fibrillation. So it's a very common disorder. Caffeine does not cause atrial fib. If that's the one thing I can make your life easier on, people come to my office all the time, Doc, can I have coffee? Yes, you can have coffee. Now, we'll talk a little bit about caffeine later. There are other things it can do that may not be the best for you, but caffeine does not cause atrial fib. And what are the symptoms? It's funny, years ago, I was stunned a couple times by seeing patients come to see me with atrial fib, and I would put down palpitations and they wouldn't check it off. And it took me a long time to realize, you don't know what are palpitations, right? So the patient comes in the room and they say, well, Doc, I say, you don't have palpitations, really? And they say, no, but I got this flip-flop in my heart. It's like a fish jumping around, or it just doesn't feel right. So what we call palpitations, which is the medical term for it, is really just a feeling of unease in the heart. You know, and if you take your pulse, it's irregular, okay? So that's a common symptom, but there are lots of others. The most important thing is no symptoms. There are lots and lots of patients who have atrial fibrillation where it's what I call the annual office exam pickup. I see patients like this every week in my office. Many of you here may have had that happen to you or a family member. You go for your annual physical, you're feeling fine, and the doctor says you have an irregular rhythm, they get an electrocardiogram, and now you have atrial fib. How long you've had it, I don't know. It's one of the things we have to work out, and it's part of the treatment plan. But what you must understand, not feeling it doesn't mean it's not dangerous. It still has the dangers of stroke attached to it if you're at risk. And just because you don't feel it doesn't mean you shouldn't be treated. So here's the thing. Apple Watches are out there now, and they're very good, all these things. But here's what I'd like to teach you, okay? Everyone has their own actual watch, and it's called your pulse, okay? This is from ancient China. Moses Maimonides, in his early writings, talks about taking a pulse. So what I want you all to do, just do a little exercise here. I want you all to follow me and take your pulse. So here's how you do it. It's right here, right around your thumb. Just put your hand there and see if you feel your pulse. Okay? You feel it? If it's not atrial, if it's normal rhythm, it's nice, steady pulse. If it's bouncing around, you either need to see me afterwards, and I'll hang around, or see your other doctor, because that's probably not good. So you take your pulse twice a day. I'm crazy on this. My wife will tell you. I actually carry a blood, my friends will tell you, I actually carry a blood thinner with me. Thankfully, I haven't had to take it because both of my parents had AFib and one died from a stroke that was his first manifestation. So I take my pulse twice a day. I make sure it's regular, just 10 to 15 seconds. Just sit there, and if it's nice and steady, don't need to worry about it. If it's bouncing around, you need to get evaluated. So you don't have to, you can buy a watch if you want to spend the $400 or $500, or you can do this for nothing, twice a day. Take your pulse.
What do you do if, let's say, you go home and you take your pulse and you find out it's irregular? I mean, is that an appointment with your doctor, or is that going to the hospital thing?
That's a good point. If it's Christmas Eve, you're probably not going to see your doctor. So if you're, I don't want to give you the wrong advice. I would say that if you take your pulse and it's irregular, take it again, let's say an hour later, it's still irregular, and you are at risk for stroke, and I'll show you the risk factors, I'd probably go to the emergency room and have it checked out. Yeah, I mean, stroke's a big deal. Yes, that's a good point. The most important way to take care of AFib is to preserve the brain. You need to know these rules. The reason you can get into trouble with AFib is you can develop a clot in the top chamber of the left side of the heart. It's called the left atrial appendage. It's there for a variety of reasons, but when blood flow is sluggish, you tend to develop clots. And if you develop a clot in that upper chamber and it dislodges, it will go most times to the brain. 23 to 25% of unknown strokes in elderly patients are found out to be due to atrial fib that was not diagnosed previously. And like my poor father, you can die from your first episode. So this is not fun and games. This is stuff that's really important. That's why I stress, if you don't know anything else, take your pulse. If you have an Apple Watch, they're pretty accurate. They overcall things. I mean, they'll call anything that's a regular AFib because that's what they do. But that's okay. At least you know something's going on. You can get help. This is actually looking with what we call an echocardiogram. Here's what I'm talking about. You see this big clot here? That's in this person's upper chamber. We had him immediately started on blood thinners, let it dissolve so that he wasn't at risk of a stroke. So are you at risk for a stroke? Well, it's based on a scoring system. It's called the CHA2DS2, and it's not perfect by any means. It's only about 60 to 65% predictive, but it's a good starting point. And each of these get weighted. So for example, if you have heart failure or hypertension or you're over 75, these all get weighted. If you have a score of 2, if you're a man, a score of 3 if you're a woman, because women are counted in there, but really it's a minor risk factor, it's been found out, then you are at about a 3 to 5% yearly risk of a stroke, if not attended to correctly, if you're not on a blood thinner. If you're on a blood thinner, you can ratchet that down by about 80 to 85%. So these are the things you see. I don't have, many of you are probably on some of these drugs. They're on TV all the time, right? They're always on TV. And then here's what it is. It's called direct-to-consumer advertising. It started years ago. And the problem with direct-to-consumer is that it's, you know, it's not like you can go order your own drug. And patients come in all the time and say, I saw this on TV. And Dr. Prystowsky, there's this big warning. You can bleed from these. They're blood thinners. Yeah, guess what? Their side effect is bleeding. I mean, that's what happens. Or you can prevent a stroke. So what would you rather lose? Blood cells, I mean brain cells, which are irreversible, or you have let's say a GI bleed, okay? Not fun, but it can be managed, and very, very few people ever die from that. So the overwhelming positivity is to take them. And which one you should be on and stuff is something that we could talk about later. I just want to make sure you're covered. And of course, Coumadin is fine to use. It's an old-time drug. It's just harder to take, has to be monitored. These drugs don't have to be monitored. So the most important thing if you have AFib is to get that right. Everything else comes to just feeling good. I mean, that's the one thing that could end your life or make you disabled for life. But there are other things you need to know about atrial fib. So one of them is, how do I keep the rate under control? And those are drugs we call either beta blockers or what we call calcium channel blockers. I use Digitalis very uncommonly now, but beta blockers and calcium channel blockers. But here's the thing. Frequently, I'll see second and third opinions, and patients will say, well, I don't understand, Dr. Prystowsky. I've been treated with 2 drugs, and I'm still having AFib. Yeah, because these are the drugs that your PCP might be giving you with the mistaken understanding they will actually stop your AFib. They don't do that. Here's what they do. I'm going to give you an analogy that's, I think, a little easier to understand than trying to explain to you the AV node conduction system. So you just need to know, my wife helped me with this because I'm famously known not to cook at all. I basically know how to turn on a microwave occasionally, but I understand this is true. So if it's not, you can blame my wife. So imagine you're in the kitchen trying to strain something through a strainer, and the water's pouring through, and you have a strainer, and the water's coming out, right? So what could you do? You could say, all right, I'm going to put some plugs in there, and less water's going to come out. That may not be what you would do. Maybe you'd turn off the water. You can't turn off AFib. So imagine you have 400 to 500 impulses flooding down into this strainer called the conduction system. So how do you have fewer get back down? You put some plugs in there, and those plugs are called beta blockers or calcium channel blockers. They do not stop AFib. They only slow the rate. That is not what the drug you need to be on if you're going to get yourself back to normal rhythm, okay? Very important, because this happens all the time. I see this on a weekly basis. I don't know what to do, Dr. Prystowsky. All the drugs I'm taking have failed. No, actually, I love this because I have everything available to me. Now, you've been tried on nothing at this point, and we'll get you fixed. So these are the drugs, I won't go into them, that you use to try to keep your normal rhythm. We also have alternatives. I don't want to go into great detail, but we can try to fix you in a special electrical catheter lab by actually finding the sources of AFib and getting rid of them. Here's a good trivia question. So what is the only veins that carry oxygenated blood? Pulmonary veins, right? So blood, normally the veins carry deoxygenated blood back to the heart. Okay, that's what veins do. They go to the heart. And then you go to the lungs, and then the lungs bring the blood to the heart. But that blood is oxygenated blood. So the pulmonary veins are critically important for that function. But around the veins are muscles. And it's been found out that these muscle areas are the typical spot for AFib. And here you can see in the lab, here's someone in a nice normal rhythm, and they suddenly go out of rhythm. And here's a catheter sitting in a vein. You can see how the electrical activity just starts going haywire. So what we do in the lab as an alternative to drugs, but it's an individual thing. It's not one better than the other. We go in the lab and we wall off the veins. You can see these red lines here. And when you wall off the veins, in most people, the AFib stops. And you can see it stops here. So there are alternatives. It's too complicated to go through today, but you need to know this. And when you see your cardiologist or electrophysiologist, you need to be armed with this information. Which drugs do I need to be on? First and foremost, prevent a stroke. And then try to make you feel better. Do you want to be in normal rhythm or not? If you're not, you don't care about being in normal rhythm, at least make sure the rate's controlled so you have a decent lifestyle. If you want to be back in normal rhythm, you have to consider these other drugs. But that's a discussion that you're going to have with your specialist. So before I end, I wanted to cover 2 other areas. So let's talk about palpitations. Because I get pulled aside at almost every event I go by somebody who says to me, Eric, I'm feeling these extra beats. What do I do? I'm scared. And it is a scary feeling because you don't know if that's something that could cause you to drop dead. And you always hear about, Billy was fine until they found him dead in bed. So no, it's the problem with sudden death. Sudden death is just that. It's the sudden, unexpected demise of a patient. There was just recently a sad case in our own hospital. I just got word yesterday, one of the pediatric endocrinologists was found dead. He's had sudden death. You always read about somebody playing ball, okay, and they die suddenly on the field. So when should you worry? If you're just having flip-flops, skip beats, occasional, jump in a pulse, or your heart you think is racing, but it's less than 100 a minute, that's hardly ever anything to worry about. Now, it may be life-disturbing. You may want it to stop, so then you have to see someone that can analyze what it is and give you the right medicines, but it's not life-threatening. These are the things that you need to worry a little bit about. Let's say you're a little lightheaded, and you take your pulse. You know how to do that now, right? You take your pulse, and oh my God, it's 20 beats a minute. That's not good. Now, you need to see somebody. You're maybe in heart block, or there's something going on, you need to see someone. Or you don't feel good, and you take your pulse and you're going 180 a minute. That's not good, right? You shouldn't go 180 a minute sitting there relaxing. Even if you're excited, you don't go 180 a minute. If you have a fast heart rate, an irregular heart rate, a really slow rate, those are the danger signs, and you need to see someone. And for this young lady back here, yes, if your doctor's not there, call the emergency room. There's one of those there. Just to stay on tight, right? Since you want to know what, those are the ones where you do need to worry. If it's skipping, just a skip beat, no. You can sit and wait till Monday and call the office. Dizziness is a common symptom, but it's not just about dizziness. You have to know there's a differential here. There's a difference between dizziness, lightheadedness, and passing out. True dizziness, like the room spinning or you're spinning, is almost never due to heart conditions. It's inner ear, it's in the brain. Now, I know you'll call my office and say, I'm feeling dizzy, I want to be seen today. I've instructed Marilyn, who's speaking, is going to speak later back there, my Uber nurse, to always find out, is the room spinning? Are you spinning? Or are you actually feeling like you're going to pass out? If you're feeling like you're going to pass out, I need to see you. If the room's spinning, call your favorite ENT person, because it's almost always an ear problem. Lightheaded is different. Lightheaded is that feeling like, geez, I'm going to pass out. Not spinning. It's a graying out feeling. You know, I'm just not there. That's usually blood pressure, but it could be a heart rhythm. So that has to be investigated. And if you actually pass out, if you literally pass out, you need to be investigated. Now, oftentimes it's nothing. I mean, it's just a blood pressure issue, or you had, some people get what's called a vagal spell, but it has to be investigated. So don't mess around with those. So lightheaded and syncope, you need to take seriously. Room spinning, see your ENT or PCP or something, it's hardly ever the heart.